Hello, guys. So today we're going to discuss respiratory system examination or pulmonary examination. We're going to go through it very briefly, and we're going to try to make it easier for you and finish it up and wrap it up in 5 minutes, hopefully. So let's get started. So starting off with a general examination, like any other system, you should always inspect your patient, the general condition of your patient. Are they in distress? Are they comfortable in bed? Is there any change in their posture? Are they taking a certain posture to make them more comfortable? Is there any pallor that can indicate anemias? Are they cyanotic or their color is normally colored? Are they in pain? Is there any pain during breathing, and that can indicate pleuritic chest pain for us? Is there any nail clubbing when you go and approach them? And check their nails, check the nail bed, look at the angle between the nail bed and the end of the phalanx, the distal phalanx, and check if there's an angle, increased angle between them. And you can also do the Skamritz sign or the Skamritz window, and you can ask your patient to approximate two similar phalanges and then look for the space in between these two or a window, and I'll demonstrate that in the coming slides for you in a picture. You can also check for the surroundings of your patient. Are they using any ventilation devices? Is there any inhaler around them? Is there any oxygen device they're using? Are they maintaining their oxygen saturation in room air, or are they attached to any device that could give you an idea? Are they breathing normally, or is there a pathology going on? Are there any walking aids around them or crutches? All that can give you an idea about the general well-being of the patient. And then you can move on to the chest exam after you're done with your general inspection. So once we start with the chest, as a rule of thumb, you always, any part of the body, you always, or mostly, you'll go through inspection, palpation, percussion, and then auscultation. So in inspection part, then you're gonna focus on the respiratory rate, because we're talking about the respiratory system examination. So you can check the respiratory rate by counting how many breaths, just observe the chest movement of the patient and count over 1 minute. If it was more than 20 minutes, more than 20 breaths per minute, it's gonna mean that there's tachypnea. If it was less than 12, then our patient is bradypneic, and then he needs further assessment. You can also look, is it symmetrical, or is one side moving more than the other or downward in relation to the other? That could also indicate that there's a pathology on one side. Look for tracheal deviation. Is it a hyperinflated chest? Hyperinflated chest usually normally means that there is some obstructive pathology going on. So remember, obstructive versus restrictive. An obstructive pathology normally gives us a hyperinflated chest, while the restrictive wouldn't give us this picture. Look for any surgical scars and bruises. Ask our patient if he did any scars, but you have, from the observation, you have to tell whether there was any surgical scars, like median sternotomy, a lateral sternotomy, etc. Then look for any chest deformity. The two common deformities we can get asked on exams are usually pectus excavatum and pectus carinatum, and I'm gonna demonstrate that in a picture for you. So here's pectus carinatum, in which there's an invagination inwards of the chest down, and then here it's bulging, and then in excavatum, or they call it the shoemaker chest, as if there's a shoe, the shoemaker, when they put the shoe on their chest in order to clean it. So they call it the shoemaker chest. So it'll be going inwards. Going back to the respiratory distress signs, you have to check for any accessory muscle use. So is the patient using the sternocleidomastoid muscles or the accessory muscles? Is there any intracostal recessions while breathing? All this can give us an idea if our patient is in distress or not. And then finally, we've got something called the Pemberton sign, in which you ask your patient to raise their hands and look for plethora of their face or distended neck veins. Normally, this would happen when we've got pathology or a mass obstructing our superior vena cava or the neck veins. And a very good example of that is the SVC syndrome or superior vena cava syndrome. Moving on, this is the digital clubbing. I tried to demonstrate it here. This is the Skamritz window or Skamritz sign. In A over here, it's the normal. Normally, you should see this window. In patients with clubbing, an increased angle between the nail bed and the phalanx or the end of the finger, there'll be this contour, it'll be lost, and then the window is lost over here. Now, moving on to palpation, you would normally or generally ask if they're in pain, and then you can go ahead and start with your palpation and try to be gentle, especially if your patient is having any pleuritic chest pain. You can assess for tracheal deviation on palpation, not only by inspecting. So this can happen by just placing 3 fingers, your middle 3 fingers on the neck. Third finger should be on the trachea itself, and then check the distance between these fingers. Is it equal on both sides or not? This way you can assess for tracheal deviation. Obviously, tracheal deviation can mean that I have got a mass, or I've got building up of fluids, or a mass that is on one side. It would shift the trachea to the opposite side. So it would always indicate that there's a pathology on the opposite side. Check for tenderness or rib pain, especially in those who are coming to you with trauma. You have to check if there's any rib fracture, any crackling sound when you palpate, any crumbling when you put your hand. You can palpate also lymph nodes, especially cervical, for any mets in those whom you're suspecting they may have any mets or any lymph node enlargement. You can mainly check the cervical and the axillary. Then you would check the chest expansion by placing both your hands around the chest and asking your patient to take a deep breath and assess the symmetry and the distance between your thumbs. And normally it shouldn't be more than like 3-4 centimeters max. Now, tactile fremitus. Now, tactile fremitus should be assessed while asking your patient to say certain numbers like 99 or 44, and while saying that you should be palpating both sides of the chest, checking for increased vibration as they say that. If there was increased vibration or the sound was propagated to your hand very in an exaggerated way, then this can mean that there's a mass, like a consolidated mass, consolidation, or pneumonias. It would propagate the sound to you more, in a more exaggerated way. If it was decreased, on the other hand, we would suspect that there'd be like air, pneumothorax, or effusion, building up of fluid around your chest. Moving on to percussion. Now, generally, I would like to demonstrate to you the idea of getting dividing the chest into, let's say, 3 parts. And then, so here's the chest. You can generally, for percussion and for auscultation, it will be very helpful if we divide the chest into 3 main areas to cover the 3 lobes of the lungs, or the 3 main areas, upper, middle, and lower areas of the lung. So if these are the clavicles, and here's the nipple over here. So you can start by percussing. Let's say percussion for percussion, auscultation, this applies for both. So you can start by auscultating in this area and then move on to the next, or percussing here, moving on to the next. So generally just divide your chest into these 3 areas, and you can start by above the nipple, below the clavicle, to assess the upper lobe, and below the nipple over here, somewhere here, to assess the middle lobe, and then move on down a little bit down to assess the lower lobes. And if you want to be very comprehensive and check the axillary part, you can go down to the mid-axillary line and assess the rest of the lungs. We can do the same on the back. So here's, if we divide the back this way, and here are the scapulae. We're going to use the scapulae for us as a landmark. And this is the scapula. You can start above the scapulae, and then in between the 2, and then below the scapulae. And it's very important to note that we should always compare both sides. So I would percuss one side and move on to the other. Percuss one side, move on to the other, and compare both and see what you note on examination. The chest percussion obviously is going to help us in differentiating the type of pathology there. So normally I would percuss and expect that it would be resonant. Any consolidation could give us a dull sound. Any buildup of fluid or pleural effusion would give us a dull sound as well. Any collapse or fibrosis would also give us a dull sound, and only pneumothorax would I expect hyper-resonant sound when I percuss. Now for auscultation, I'm going to apply or move on this in the same way. Auscultate all areas of the lung in the same order. Normal physiological breath sounds are going to be called vesicular sounds, and vesicular breath sounds is a very low pitched sound in which you've got prolonged expiration, and then after that you're going to get a short period of expiration, and this is the normal physiological breath sounds. So inspiration first, and then you've got your expiration, very short period. While on the other hand, we've got the pathological breath sounds in which you've got bronchial sounds, and the bronchial sounds, there are high-pitched sounds in which you've got almost equal inspiration with prolonged expiration following it. And we're going to discuss the more pathological or added sounds. So what are added sounds that we're looking for during examination? I just highlighted for you the most important ones. So wheezes, in which we've got, or usually they indicate lower airway obstruction. In lower airway obstruction, there is always asthma on our mind, should be asthma on our mind and COPD, because these are one of the high yield points that you should know. Once you've got wheezes, it means that there is lower airway obstruction. Once we hear stridor, on the other hand, it means that there's an upper airway obstruction, usually epiglottitis, foreign body aspiration, very common and important, and emergencies actually that we should take care of. Finally, we've got crackles or rales in which there are air pockets obstructing the airways. This is commonly seen when we've got patients with pulmonary edema or COPD. And last but not least is rhonchi, which are low-pitched wheezes, very similar to wheezes, but you can see them normally in upper respiratory tract infections or due to buildup of secretions in the upper airway. And that wraps up our presentation for the day. Thank you for watching.